Good evening, everyone. My name is Dr. Amar Swali. I'm a consultant physician and nephrologist working with Sri Hindu Mandal Hospital in Dar es Salaam, Tanzania, and I take great pleasure in inviting you all in the Africa Healthcare Network Fireside Chats Series 121. It is my pleasure to introduce tonight's speaker. His name is Dr. Dominic Raj, and he has previously also had one more talk with us on dysbiosis in chronic kidney disease, a video for which is available on our YouTube channel, Africa Healthcare Network, Fireside Chats. Dr. Dominic Raj is a professor of medicine, a professor of biochemistry and genetics, a professor of epidemiology and biostatistics at the George Washington University School of Medicine. And he's also the director for the Division of Kidney Diseases and Hypertension at George Washington University School of Medicine. Dr. Dominic Raj is a tenured professor of medicine and is the chief of the Division of the Kidney Diseases and Hypertension. And he's an accomplished researcher with more than 175 peer-reviewed publications and has been invited all across the world to share his clinical and research expertise. He's a translational researcher with a focus on genetic epidemiology, clinical trials, inflammation, cardiovascular diseases in CKD, non-coding RNAs, and microbiome. And his research has been supported continuously by the NIH since 2003. He will be speaking to us tonight on clinical trials and their impacts on hypertension, on dialysis. So Dr. Dominic Raj, please, the floor is all yours. Thank you so much.
Thank you. Thank you. I'm blushing. It's more than 250 publications. That was Volt.
I'll update that for next time.
That's okay. I'm just saying. Okay. The topic I chose, this was by advice from Vincent, is the hypertension in dialysis. Before I go forward, I want you to take a look at this slide. This is a study that was done in early 19, probably in the 50s, which looked at the association between renin-angiotensin system and the volume status. As you can see, the relationship between volume and the renin-angiotensin system is inverse. This is very critical for us to understand when we discuss the pathophysiology and the treatment option for hypertension in dialysis patients. So there's a case. On a Monday morning, you are called to see from the outpatient dialysis that one of your patients has a systolic blood pressure of 174 millimeters of mercury and is short of breath, but saturating pretty well. He weighs about 72 kilos and is about 3 kilos above his dry weight. He has a history of diastolic heart failure. What will you do? Instruct the nurse to send the patient to the emergency department immediately. Give clonidine, and once the blood pressure is less than 160 millimeters of mercury, dialyze the patient. Request to hold dialysis till you come and evaluate the patient. Or will you initiate the dialysis? You will initiate the dialysis. So the objective of this discussion will be as follows. Now I'm going to talk to you about measuring blood pressure in dialysis patients. Hypertension is very common in dialysis patients, affecting about 70 to 85% of the patients. About 90% of them are actually treated with medication, but only 50% of them achieve blood pressure control. But before we define the prevalence, we should know how to define hypertension. The blood pressure progressively increases from post-dialysis to the next dialysis session. So which blood pressure will we use? Pre-dialysis, intradialysis, post-dialysis, or in between dialysis blood pressure? That is what we are going to look at here. So in this study, Agarwal et al. Did a meta-analysis in which they compared blood pressure that is measured in the dialysis unit, and the patients had 24 hours blood pressure monitoring. They also had home blood pressure monitoring. The study shows clearly that the pre-dialysis systolic blood pressure overestimates and the post-dialysis systolic blood pressure underestimate the mean ambulatory blood pressure monitoring, which is considered to be the gold standard. So does it matter whether it correlates with ambulatory blood pressure monitoring? What we want to see is, does it correlate with the clinical outcome? This study involved about 150 patients who had simultaneous measurement of hemodialysis machine measured blood pressure in the dialysis unit. In the dialysis unit, they also use sphygmomanometer to measure the blood pressure. Then they ask the patient to measure home blood pressure monitoring 3 times daily for 1 week. And they also underwent ambulatory blood pressure monitoring at midweek. As you can see, the only association they found was with the home dialysis and ambulatory. These patients were followed for about a year. And home blood pressure monitoring and ambulatory blood pressure monitoring showed a dose response increase in mortality. So the European Renal and Cardiovascular Medicine Group concluded that no recommendation can be made on the basis of pre or post-dialysis blood pressure, but should be defined on the basis of home blood pressure monitoring or ambulatory blood pressure monitoring. They define hypertension as a blood pressure more than 135 mmHg/85 for measurements derived from morning and evening blood pressure recording over 6 non-dialysis days. A target is 130/80 if it is based on ambulatory blood pressure monitoring over 24 hours during the midweek day that is free of dialysis. Ideally, they said you should measure for 44 hours. When home blood pressure monitoring and ambulatory blood pressure recording is not available, they recommended using an office blood pressure measurement taken during midweek day that is free of dialysis. They recommended an office blood pressure target of 140/90. So let's move on to the next one, blood pressure target in dialysis. So this is a study done by Phil Zager using the DCI database, which included about 5,400 patients. And the analysis showed blood pressure had but modest effect on outcome. An elevated pre-dialysis blood pressure is not associated with mortality. Low systolic blood pressure of less than 110 millimeters of mercury, both pre and post-dialysis, were associated with cardiovascular and all-cause mortality. Post-dialysis systolic blood pressure of more than 180 millimeters of mercury was associated with increased cardiovascular mortality. So this same group looked at the blood pressure as a time-dependent variable. That means they, instead of using one blood pressure, mean blood pressure, they looked at the change in blood pressure over a period of time. And they found a systolic blood pressure of less than 120 was associated with increased mortality in the first 2 years of after starting dialysis. But as blood pressure of more than 150 millimeters of mercury were associated with increased mortality after 3 years. In other words, a low blood pressure was predictive of early mortality, and a systolic elevated blood pressure more than 150 was associated with mortality after 3 years. The same topic was taken up by the DOPS investigators. They observed that uncontrolled blood pressure is not associated with mortality, but a pre-dialysis systolic blood pressure of less than 130 millimeters of mercury and a diastolic blood pressure less than 60 millimeters of mercury was associated with increased risk of death at patient level and facility level assessment. So based on the existing, this is the KDIGO took up the same controversial topic. They came in roaring and went back as a lamb. So they concluded, based on the existing evidence, definitive recommendation regarding blood pressure treatment targets cannot be made for dialysis patients. An individualist approach is necessary for dialysis patients with a particular focus on avoiding low blood pressure and special consideration for intra and intradialytic BP patterns, volume measurement, and comorbidities. Basically, it was a vague recommendation, but did not give any specific instructions. Next, what is the etiology of hypertension? It is very important because once you know the etiology, you can manage it better. Another one question. The most important cause for hypertension in ESRD patient is activation of renin-angiotensin system, sympathetic overactivity, salt and water retention, or endothelial dysfunction. The answer is salt and water retention. Several factors contribute to hypertension in dialysis patients, besides the fact that the hypertension could by itself have contributed to the ESRD. Volume overload is a key player. For the others include activation of renin-angiotensin system, sympathetic overactivity. In fact, the end-stage kidney does not produce renalase. Renalase is an enzyme that degrades catecholamines. There is endothelial dysfunction with nitric oxide and endothelin-1 imbalance, high prevalence of sleep apnea. There is some data to show that sleep apnea can increase the blood pressure. In fact, but the data from nocturnal hemodialysis shows some of the sleep apnea in dialysis patient is because of the glottic edema. And there are people who claim use of recombinant erythropoietin could be one of the causes for uncontrolled hypertension. This study was published in 1969, which describes the volume and renin-dependent nature of the hypertension in dialysis patient. Among the 40 patients studied, 35 responded to ultrafiltration by reduction in blood pressure. The 5 patients who did not respond to ultrafiltration underwent nephrectomy, bilateral nephrectomy, and their blood pressure was controlled. Among these patients, the plasma renin activity was higher than those with ultrafiltration. Plasma renin activity was higher. So the predominant cause for hypertension is volume dependent, and those who are resistant, you should consider activation of renin-angiotensin system. So why is the renin-angiotensin system activated in this patient? In a healthy kidney, most of the angiotensin 1 is converted to angiotensin 1 to 7 fragment by neprilysin, whereas its conversion to angiotensin 2 is quantitatively less. This results in tilting of the renin-angiotensin towards a protective effect of decreasing blood pressure and pro-inflammatory molecule production and extracellular matrix expansion. In patients with chronic kidney disease, less angiotensin 2 is converted to angiotensin 1 to 7 fragment, whereas the kinase takes over, which results in conversion of angiotensin 1 to angiotensin 2. Thereby, they have an excess angiotensin 2 level for a given level of volume. What about activation of renin-angiotensin system? Sympathetic system. In this study, investigators recorded the post-ganglionic sympathetic nerve discharge to blood vessels in skeletal muscle by microelectrodes placed in the peroneal nerve in ESRD patients. They compared it with ESRD patients who are undergone bilateral nephrectomy and normal subjects. As you can see, there is not significant difference between normal and patients who have undergone bilateral nephrectomy, but it was significantly different with excitation of the sympathetic system in patients who have intact ESRD kidney. Thus, they concluded chronic renal failure may be accompanied by reversible sympathetic activation, which appears to be mediated by an afferent signal arising from failing kidney. One hemoglobin molecule carries 4 oxygen molecules. In the presence of anemia, in order to deliver more oxygen to the tissue, several changes occur, including increased cardiovascular output, tachycardia, and peripheral vasodilatation, resulting in lower blood pressure. When these patients are treated for anemia, with the anemia is treated, these are reversed. And hence, treatment with the erythropoietin results in correction of anemia, resulting in normalization of the decreased peripheral vascular resistance and reduction towards normal in the elevated cardiac output. As a result, you see the cardiac output decreasing, the systolic blood pressure increasing, and peripheral vascular resistance also increasing. One important finding is in this study, which involved about 63 patients, that about 6 patients developed grand mal seizure. And rapid correction of anemia and elevation of blood pressure leading to hypertensive encephalopathy heralded in a fear in using such therapy in ESRD patients and hypertension. We will explore this myth further. The reported prevalence of new onset or worsening hypertension with EPO use is 30%. Mean increase in systolic blood pressure is about 8 to 12 millimeters of mercury. Hypertensive encephalopathy is mostly confined to earlier reports where a large dose of EPO was used and the correction of anemia was targeted to a higher level. The etiology of hypertension with the EPO use is increased blood viscosity, elevated endothelin-1, and sensitivity to angiotensin 2 and adrenergic stimuli. So that leads us to think whether we should EPO or not EPO. So if you have to use EPO in this patient, use a lower dose. Mostly it is the IV use that is associated with hypertension crisis. So use it subcutaneously if the patient has elevated blood pressure. If a patient has blood pressure above 180, control the blood pressure before starting EPO. If the patient has a tendency for seizing, first start the patient on medication to control the seizure activity before initiating EPO. So it is not absolutely contraindicated, but it just needs a precaution before starting erythropoietin. Next topic, management of hypertension in dialysis patients. Is it beneficial to treat hypertension in dialysis patients? This meta-analysis of data from clinical trial that involved about 1,600 patients showed that blood pressure lowering treatment was associated with 29% lower risk of cardiovascular events and 20% lower risk for all-cause mortality. However, none of these studies included where either in this meta-analysis specifically targeted blood pressure levels, but designed to estimate the effect of specific antihypertensive medication with independent cardioprotective properties. So the results should be taken with a pinch of salt. This is the only randomized controlled trial that is available, which included 126 hypertensive dialysis patients. They were randomized to a standard pre-dialysis systolic blood pressure of 120 to 140 millimeters of mercury or 150 to 165 millimeters of mercury. The average difference in systolic blood pressure across the two arms were 12.59 millimeters of mercury. The median follow-up was about a year. Although the study demonstrated feasibility, there was no difference in any of the clinical endpoints such as the major adverse cardiovascular events, hospitalization, vascular access thrombosis, or emergency room visits. The change in LV mass in both arms were comparable. So this study by Rahman examined the determinants of inadequate blood pressure control in dialysis patients, which included about 500 patients. The prevalence of uncontrolled hypertension defined as systolic blood pressure more than 160 was about 60%. 90% of the patients with uncontrolled hypertension were receiving suboptimal antihypertensive therapy. And 59% of the patients withheld their medications before dialysis. Those with uncontrolled hypertension had a greater intradialytic weight gain. They are more likely to be blacks with ESRD secondary to hypertension and on dialysis for a shorter duration of years. So beware of pseudo-resistant hypertension. It's a wrong if you use the wrong technique, you'll get the wrong reading, wrong size of the cuff, wrong posture of the arm, wrong time. When the patient is anxious and angry, if you measure blood pressure, it will be high. Medication non-adherence, especially if a patient was on clonidine, all that you need to do is to reinstitute the therapy. Wrong distribution of the medication around the dialysis period. Sometimes all that you have to do is to move the medications around to get a more optimal 24-hour control of blood pressure. Midodrine use. Cardiologists always love this midodrine. If a patient is using midodrine, naturally he will have pre-dialysis systolic hypertension. There is beware of conflicting instruction from the primary care doctor, cardiology, and nephrology. The patients sometimes bring 3 packets, one prescribed by the cardiologist, one by the primary care physician, one by the nephrologist. It's very important to reconcile these medications. Let's look at the non-pharmacological treatment. Scribner observed that hypertension appears to be influenced by the size of the extracellular space. The combination of dietary sodium restriction and ultrafiltration during dialysis treatment permits regulation of extracellular volume and control of hypertension. So why is the dry weight so elusive in dialysis patient? There are several barriers to achieving dry weight. There is no objective way of assessing dry weight. We use in some patients point of care ultrasound care. There is an inertia on the side of the patient to decrease the dry weight. When the patient doesn't want, the physician follows suit. He doesn't drop the dry weight. The patients are quite often non-compliant with sodium restriction, and we may be using an inappropriate dialysate sodium. Short dialysis treatment precludes achieving a dry weight. When the patient is symptomatic with hypotension, cramps, and nausea, we stop ultrafiltration and give back the fluid. And concomitant diseases such as heart failure and autonomic dysfunction makes it difficult to achieve dry weight in these patients. So this is the DRIP study done by Rajiv Agarwal examined the effect of programmed ultrafiltration on blood pressure. They instituted ultrafiltration profiling, which resulted in about 1 kilo weight loss at the end of 4 weeks, which was associated with 7 millimeters of mercury systolic blood pressure drop. On the following 4 weeks, this decrease in blood pressure and the dry weight was maintained. In other words, you can sustain the blood pressure and sustain the low dry weight by aggressive ultrafiltration. If that is a miracle treatment, why are we not using? The secondary analysis of the data from HEMO study showed that the risk of all-cause and cardiovascular mortality began to increase with ultrafiltration rates over 10 ml per kg per hour. In the adjusted analysis, there is a distinct increase in all-cause and cardiovascular mortality, about 10 to 13 ml per kg per hour ultrafiltration. So why do they have increased mortality with aggressive ultrafiltration? Braunwald described myocardial stunning as as delayed recovery of regional myocardial contractile function after reperfusion, despite the absence of irreversible damage, and despite restoration of normal flow. Myocardial stunning is driven by ischemia, is recognized as a complication of hemodialysis. In this study, 70 hemodialysis patients were assessed for evidence of subclinical myocardial injury using serial echocardiography performed pre-dialysis, during dialysis at both 2 and 4 hours and 30 minutes into the recovery period. 64% of the patients had significant myocardial stunning during hemodialysis. Age, ultrafiltration volume, intradialytic hypotension, and cardiac troponin level were independent determinants of regional wall motion abnormality. When these patients were followed for about 12 months and echocardiography performed, the so-called reversible ischemic changes became fixed defect, resulting in low systolic blood pressure and low ejection fraction, causing irreversible damage. In Tarsin, France, patients received 8 hours of dialysis thrice weekly using cellulose membrane. In this study, they evaluated the monthly change in post-dialysis weight and blood pressure over 12 months in 60 patients. The post-dialysis weight progressively decreased up to 2 months and then increased due to increase in lean body mass attributable to net anabolism. The blood pressure progressively decreased and 90% of the patients were off antihypertensive medication. In this study, 9 patients were switched from conventional dialysis to nocturnal hemodialysis, where patients received 6 hemodialysis, each lasting for about 6 to 7 hours. All the patients were on antihypertensive at beginning. With progressive adjustment in dry weight, the blood pressure was controlled better, and 5 patients discontinued antihypertensive, and ultrafiltration was very well tolerated. In the study, they compared the ultrafiltration volume, ultrafiltration rate, the regional walls motion abnormality in patients on conventional hemodialysis, short frequent hemodialysis, short hemodialysis at home, and home hemodialysis. And as you can see, ultrafiltration volume was lower in home nocturnal dialysis than home short hemodialysis, which resulted in lower number of regional wall motion abnormalities. The dialysate sodium has undergone drastic change over the last 50 years, which was driven by the technological advances and desire to improve the tolerability of hemodialysis procedure by the patient. Higher dialysate sodium concentration generally promotes hemodynamic stability and reduce intradialytic symptoms, but often do also at the expense of this stimulating thirst and promoting volume expansion. We can quench the thirst in dialysis patients by reducing the dialysate sodium. This is a study we did when I was in St. John's Medical College. In a double-blind crossover trial, 22 stable hemodialysis patients were subjected to conventional hemodialysate with dialysate sodium containing 137 milliequivalents of sodium and constant ultrafiltration, or to dialysate therapy, in which by linear sodium modeling, the dialysate sodium was reduced from 137 to 128. A computerized ultrafiltration program was used to gradually reduce the ultrafiltration volume to minimum towards the end of this session. Severity of the thirst and intradialytic weight gain and intradialytic complications were lower with low sodium dialysate. It allowed adequate ultrafiltration with absolute hemodynamic stability. The same concept was introduced later on in 2004, in which they recommended using individualized dialysate sodium, which was defined as average pre-dialysis sodium of the patient, which was multiplied by 0.95. This is to accommodate for the Donan's equilibrium, and they again showed they were able to ultrafilter. The patients were able to tolerate ultrafiltration better, with lower intradialytic weight gain and the patient's tolerability to ultrafiltration was better. Now let's look at the pharmacotherapy. In patient, this is a study done by Kevin Abbott, which involved which looked at the retrospective data from USRDS database. In patients without previous history of heart failure, beta blocker use was significantly associated with lower adjusted risk for heart failure, with similar reduction in risk for cardiac-related and all-cause mortality. Beta blocker use, on the other hand, had no statistically significant association with outcome in patients with previous history of heart failure. But not all beta blockers are equal. They can be lipid-soluble beta blocker. They can be water-soluble beta blocker, which is cleared by the kidney and removed by dialysis. They can be cardioselective beta blocker, or they can be vasodilatory beta blocker. And there are beta blockers with some intrinsic sympathomimetic activity. This study one was done by Matt Weir from University of Maryland. Other one was done by Wu et al. Both are retrospective study. The first one by Weir suggested poorly dialysable beta blockers using poorly dialysable beta blocker have a better survival. However, in this study, bisoprolol was considered as a poorly dialysable beta blocker. On the other hand, the study by Wu et al. Showed that the dialysable beta blockers have a better survival. In this study, the bisoprolol was reclassified as a dialysable beta blocker. So the difference, they actually arose from distribution of the bisoprolol in the two studies. Carvedilol is a non-selective beta blocker with an additional blockade of alpha-1 adrenoreceptor. It's a poorly dialysable and has a vasodilatory properties. A total of 111 dialysis patients with dilated cardiomyopathy were randomly assigned to receive either carvedilol or placebo in addition to standard therapy or placebo. After 2 years, fewer patients with in the carvedilol group died, and also the composite of cardiovascular death and hospital admissions among patients receiving carvedilol was lower compared to the placebo group. The same bisoprolol is a cardioselective beta blocker that is eliminated equally by liver and the kidney. This study compared the risk of all-cause mortality and major adverse cardiovascular events between carvedilol and bisoprolol users using a 2-year follow data. Bisoprolol initiation was associated with lower all-cause mortality, major cardiovascular events, heart failure, and ischemic stroke. Atenolol and metoprolol have high beta-1 selectivity and low to moderate lipophilicity, making them readily dialysable and placing them in distinction to carvedilol and levetolol. In this retrospective cohort study, approximately 5,000 chronic dialysis patients were treated with cardioselective or non-cardioselective beta blockers. Use of cardioselective beta blockers were associated with 16% reduction in all-cause mortality and 14% reduction in cardiovascular mortality and morbidity. This study had the objective to evaluate the effect of fosinopril on cardiovascular endpoints in patients with ESRD on hemodialysis. Eligible patients were randomized to fosinopril 5 mg titrated to 20 mg daily, plus conventional therapy for 24 months. The primary endpoint was a combined fatal and non-fatal first major cardiovascular endpoint. No significant benefit for fosinopril was observed in the intention to treat analysis. In this open label randomized control trial, effect of treatment with angiotensin receptor blockers any angiotensin receptor blocker, versus those the patients who did not receive angiotensin receptor blocker were studied. The primary endpoint was mortality, and the secondary endpoint was all-cause mortality. Study population included 366 patients. Angiotensin receptor blocker was independently associated with reduced fatal and non-fatal cardiovascular events, but difference in mortality did not reach statistical significance. A meta-analysis of the data from 5 RCTs involving 151 individuals concluded that treatment with angiotensin receptor ACE or ARB reduced LV mass in patients receiving hemodialysis. However, their use was not associated with significant reduction in risk for fatal and non-fatal cardiovascular events. This study evaluated the effect of amlodipine, the calcium channel blocker, on cardiovascular events in patients in 251 hypertensive hemodialysis patients. The primary endpoint was mortality from any cause. The secondary endpoint was composite of mortality from all cause or cardiovascular event. There was no significant difference in death, but the composite outcome was significantly reduced in the amlodipine. So we have a significant number of patients who come with uncontrolled hypertension. How can we manage these patients? Antihypertensive agents, which have a long half-life in renal failure, such as lisinopril, and those who are intrinsically have a long or long-acting, like the transdermal clonidine and amlodipine, when administered on the dialysis day, when they come for dialysis unit, you can achieve blood pressure control. This is a pilot study which showed there was a significant reduction in blood pressure pre-dialysis in patients who were treated during the hemodialysis session. So in 309 oligoanuric patients on dialysis, they were randomly assigned to receive 25 milligrams of spironolactone or to those who did not receive one. The primary outcome was a composite of death and cardiovascular events or hospitalization for cardiovascular events. And the secondary outcome was a death from all causes. The primary and secondary outcomes were significantly reduced in the treatment arm. The potassium did not significantly increase in this patient. I'm not saying use in all hemodialysis patients. You may want to choose those patients with low potassium, and you can use spironolactone with careful monitoring. So let me summarize the medication use. Carvedilol may reduce mortality in hemodialysis patients with dilated cardiomyopathy. Bisoprolol, a cardioselective beta blocker, may have some advantage in dialysis patients. ACE and ARB may reduce LV mass, which is associated with long-term reduction in cardiovascular mortality. Amlodipine reduces cardiovascular events in hemodialysis patients. Spironolactone is not absolutely contraindicated in ESRD patients. Long-acting BP blood pressure medications given intradialysis in the dialysis unit might enable control of blood pressure in non-compliant dialysis patients. Let's look at the intradialytic hemodynamics. Among 438 prevalent hemodialysis patients enrolled in the CLIMB study, 12.13% of the patients exhibited an increase in systolic blood pressure of more than 10 millimeters of mercury from pre-dialysis to post-dialysis. Intradialytic hypertension was common in older patients on multiple BP medication, those with lower dry weight and lower intradialytic weight gain. Subjects whose systolic blood pressure fell with the hemodialysis had a significantly decreased risk of hospitalization or death at 6 months. Remember, if the blood pressure dropped at the end of the dialysis, it is better. They have better survival. On the other hand, whose blood pressure increased more than 10 millimeters of mercury, systolic blood pressure had a twofold increase odds of death or hospitalization. So if the blood pressure increases in response to ultrafiltration, means there is an excessive activation of sympathetic system and renin-angiotensin system. So in this study, this is a study I did when I was a resident. We examined the mechanism of dialysis-induced hypotension. The patients were divided into 3 groups: those who sustained a drop in blood pressure, those whose blood pressure was stable, and those whose blood pressure increased. And we measured exhaled nitric oxide as a measure of endogenous nitric oxide generation and plasma endothelin level. Plasma endothelin level were significantly higher in those who had intradialytic hypertension, and the endothelin nitric oxide as measured by exhaled nitric oxide were higher in patients who sustained intradialytic hypotension. Now you can actually, there is a study which they used endothelin blockade, and they showed the blood pressure control can be achieved in dialysis patients. So midodrine is a oral selective alpha-1 adrenergic agent. Cool dialysate appears to maintain blood pressure through an increase in peripheral vascular resistance, through increase in sympathetic outflow or epinephrine. In this crossover study, investigators compared the effect of these 2 therapies alone or in combination for intradialytic hypotension. Midodrine was used at a dose of 10 milligrams given 15 to 30 minutes pre-hemodialysis, and the dialysis temperature was kept constant at 37. During cold dialysis phase, the dialysis temperature was reduced to 35.5 degrees centigrade. The third phase, both these interventions were combined, that is low temperature and midodrine. The lowest intradialytic blood pressure were significantly better with midodrine and cool dialysate compared to the control phase, and the combination of the both did not add any further value in preserving the hemodynamic stability. This study compared a variety of clinical and hemodynamic outcome across adult patients who were prescribed midodrine, which included about 1,000 patients, and MASH controls that were about 2,000 patients, all of whom were receiving in-center hemodialysis in dialysis facilities in the United States. Compared to non-use, midodrine use was associated with higher rate of death and all-cause hospitalization and cardiovascular hospitalization. It may be because these patients were having poor cardiac reserve, but even in those patients, unrestricted use of midodrine may be associated with increased risk of death. Let me summarize by saying etiology of hypertension in hemodialysis is multifactorial. Ambulatory blood pressure or home blood pressure are the most reliable estimates of hypertension in dialysis patients. The blood pressure target in dialysis patient is still debated. Volume control and individualized sodium are proven non-pharmacological option. The choice of blood pressure medication should be personalized and not random. Before I conclude, please attend the Global Summit, spread the news around. It's a great meeting, and I hope you will learn something from that.
Thank you very much, Dr. Dominic. This was such an informative presentation. It was really lovely. I understand you don't have too much time left to be with us, so I will just allow a couple of questions if you don't mind. For the attendees, please do raise your hand so we can unmute you and you can ask Dr. Dominic a question, or you could just type your question in the chat box, the Q&A chat box or the regular chat box. The panelists, please feel free to unmute yourself and ask Dr. Dominic a question.
Yeah, thank you so much, Dr. Dominic, for that wonderful presentation. It was really, enlightening. One of the problems we encounter in the pediatric population, I didn't want to bring it because I know you don't do pediatrics, but the nurses will also ask you, what's the maximum amount of fluid that I can take out on this patient, right? And so it's an interesting question because, we often say just dialyze to dry weight. And as you said, it's very difficult to calculate dry weight. Now in children, it's even worse because remember, they are growing, right? And they are putting on weight. They often on that. So it's quite a challenge for us to work that out. Do you have any thoughts on that?
Could you repeat the question, please?
I said, sorry. In the pediatric population, when patients are hypertensive and their volume loaded, we often tell the nurses to dialyze to dry weight.
Yeah.
Okay. Right.
So you have problem.
Yeah.
So the most effective way is, as I said, frequent dialysis is the most effective way of achieving dry weight in these patients. The second thing, there is data to show that frequent dialysis not only allows you to achieve dry weight and control blood pressure, it improves nutrition, which is important in determining outcome. We did show in nocturnal hemodialysis that the patient's serum albumin significantly increased and the patient gained lean body mass. The same data came from the Tarsin dialysis, also showed that the nutritional status improves, the patients achieve better hemodynamic stability. So you may want to consider more frequent, at least 4 hemodialysis. In some of the patients, I use 4. It is called the least hemodialysis. Thereby, you eliminate the 72-hour long intradialytic interval.
Thank you. That's helpful. What the problem, of course, we have is, in low middle income countries, it's hard to try and introduce another dialysis session because we are really, locked up, with the dialysis unit.
We have to write a justification why we need to give extra treatment. Then it is, if you use the right word, then the CMS pays for the treatment.
Thanks. Thank you very much.
Thank you, Dr. Bhima. Just one last question, Dr. Dominic, and it's in the Q&A chat box. Michael wants your comment on how to manage a hypertensive emergency during HD.
During hemodialysis, hypertensive emergency. Okay. If the patient comes to you before hemodialysis with hypertensive, this actually happened to me. I was in a meeting with the dean. I got an emergency call from the dialysis unit telling that the patient's blood pressure is 190 systolic blood pressure, and she said the repeat blood pressure was 200 systolic blood pressure. So I could not leave the meeting, but I had to leave because I have to tell either to send the patient to the dialysis, to the emergency room, or I have to go and see. The dean heard some of the conversation and she said, Dominic, you seems to have a problem in your hand, we'll meet again. So I came back to the unit and the nurse was using a smaller cuff and she made the arm elevated as she was doing the blood pressure measurement. And the patient had not taken the blood pressure medication. So all that I did was first reassure the patient that your blood pressure is not that high. And then I told him, do you have the blood pressure medication? And he did not have the medication. So we gave him the clonidine, and I keep 10 milligram nifedipine in the unit. I gave him 10 milligram nifedipine, and actually the blood pressure got controlled. But if the patient has end organ damage, and if you think the patient is having heart failure symptoms, that is not volume dependent, or if you think the patient has a neurological deficit, then you have to send the patient to the emergency room. And we should not use certain medication, nitroprusside, for example, is contraindicated in the patient. I've often used nitro patch, which gives you acute control of hypertension. And the best part is, if the blood pressure drops too much, you can remove it and clean the nitro patch. So as far as possible, I don't send the patient to the dialysis unit, to the emergency room. The reason is the transit by itself is going to take about an hour. And before the emergency physician sees him, the patient would have sustained an end organ damage. Does it answer your question?
I believe his question was during the session itself.
During hemodialysis, intradialytic hemodialytic, hypertension. Okay, sorry. During the hemodialysis, where blood pressure increases, you have a problem. As I told you, 13% of the patients develop intradialytic hypertension. There is no clear guidelines as to how to manage these patients. They've been telling about going slowly. I will send you a slide by email. I didn't include it in the presentation because I thought I will exceed the timing. So one other thing what they say is to optimize the dry weight, because when you take extra fluid on these patients, there is an aggressive activation of renin-angiotensin system and the sympathetic nervous system. So what they are saying is go slowly on the ultrafiltration on these patients. Well, that is a preventive measure. But if a patient develops during hemodialysis the hypertension, if there is no end organ damage, still I will use the same measure what I said, using a nitro patch, giving them a clonidine. And there is one paper that used actually endothelin-1 receptor blocker. These are the three options I will use in these patients. But if they have an end organ damage, we have to send them to the hospital. I'll send you the slide separately. I have to run back to the clinic.
Okay,
thank you very much.
Thank you so much on behalf of Team Fireside, AHN, and Dr. Lloyd. Thank you for taking time out for this lovely presentation. We'll let you go now, sir. Thank you so much.